Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair of Grand Rounds. Once, way back in the midst of time, Kevin McConville contacted me to say, could we have a slot at Grand Rounds for LGBT month? And I said, yeah, I don't see why not. And that, I think, was 10 years ago. And every year since then, we've had at least one LGBT talk, and that tradition continues this year. So, first of all, I'm grateful for Kevin in the first place for reaching out and asking. And every year, as clockwork, he's in touch with me to make sure we book a slot in February. This year, two speakers. We have Hannah Barham-Brown and William Ballard, who are going to speak about the work that goes on in the medical school to ensure inclusivity, equity, and diversity, and many other things. And these talks are always very interesting to me. I think I always learn something and take something away from my own practice as these things evolve and change, and we try to improve our practice. So thank you very much for both of you for being here. Thanks to Kevin for organising. Normal Zoom rules apply, and please turn your microphones off for now whilst the talking is going on. Feel free to leave your camera on if you wish, although no one wants to watch me eat my lunch, so I'll maybe turn mine off. If you have a question, please put it in the chat or wait until the end, stick your hand up, and we'll have some real life questions. Hannah and Will, thanks very much for joining. Looking forward to your talk.
Cracking. Thanks, Tom. I'll just give Will a second to share the slides because we agreed he's far more technologically adept than I am, so it's far safer. Here we go. Okay, so thank you, Tom, for having us to speak. It's lovely to actually be able to join a grand round. Normally, I'm working on Thursdays clinically, so I've never been able to come to one in the flesh. So it's very exciting. So for those of you I haven't had the pleasure of meeting yet, I'm Hannah Barham-Brown. I'm the still relatively new, I'm going to keep pushing that as long as I can, equity, diversity and inclusion lecturer at the medical school, and I use she, her pronouns. And Will, do you want to introduce yourself?
Yes, I do. My name is William. I am a clinical teaching fellow for the university this year. I use he, him pronouns. Super excited to be here and update you on what we've been getting up to. Hannah, are you happy for me to change slides? I actually can't see myself or anybody else while I share my screen, so just let me know when you need me to click.
If you can go on to the next slide, that'd be wonderful. Thank you. So today we're going to try and cover a bit of a hodgepodge of things, to be honest, to get everyone as up to speed as possible. So first off, we're going to have a quick think about why this stuff matters, why we work so hard to try and get more LGBTQ teaching into the curriculum and tackle health inequalities more widely. So we'll have a chat about some MBCHB curriculum updates, some of the work that we've been doing. Will is going to talk us through his amazing postgraduate education project, which I'm very, very proud of him for. And then my other role alongside working at the university is as a Career Start GP. I'm working to develop gender services for NHS Tayside. I've been doing that for the last year and a bit. So I'm going to use this opportunity to talk to people about the services as they currently are, some of the challenges we're currently facing in providing our trans and non-binary patients with care, and talking through some of the proposals that we've made for the future. So hopefully that should be quite a broad list of things to get through. If you just want to skip to the next slide, please, Will.
Absolutely. So as Hannah said, that we're going to start with why do we need to improve things? So we want to give you a little bit of information that might be a couple of statistics, epidemiology of what you can take away and have a little bit of knowledge about. So to start, I wanted to show you this slide. So this is something that has been calculated off of the most recent Scottish census data that was released a couple of years ago. So approximately 4% of people within Scotland identify as a different sexuality other than straight. So that could be lesbian, gay, bisexual, and any other identities that come under that. And approximately 0.44% of people in Scotland identify as transgender or non-binary. Then if you take a little bit of time to do a little bit of maths, we can calculate actually what those populations approximately are within NHS Tayside. So it actually stays very similar for LGBT plus folk. It stays at approximately 4%, about 1 in 25 of the local population, and transgender a little bit higher, kind of at 0.5%, so 1 in 200 people. But an interesting fact that I found out from the most recent census is that Dundee City actually has the highest percentage of transgender people in Scotland. So if you're someone that lives as part of Dundee, that's a good fact to know. So
fantastic. Yeah, just looking at some statistics here. So there's lots and lots of data out there exploring some of the health inequalities that people face. So here are some of the three most stark that kind of stood out to us. In the TransLive survey of 2021, 70% of participants had encountered transphobia when accessing healthcare services, which is just kind of pretty horrifying, to be honest. We tend to think we're quite good at this sort of thing until we actually ask people from the community, and then we hear a very different story, unfortunately. 1 in 10 LGBTQ plus people in Scotland, so around 13%, have experienced unequal treatment from healthcare staff due to their LGBTQ plus identity. And that's from the LGBT in Britain Health Report 2018. And almost 1 in 4 people, 1 in 4 LGBT people, so 23%, have witnessed discriminatory or negative remarks against LGBT people by healthcare staff. So these attitudes are out there and our patients are hearing them, which is quite devastating when you think about it.
So to kind of give you some idea of what kind of backs up how you should treat your patients, we always like to go back to the basics and go back to legislation. So you'll see these two acts that are in front of you, and I'd hope that most people would know these acts by now, but you've got both the Gender Recognition Act from 2004 and the Equality Act of 2010. And essentially, these are both in place in law to help protect certain characteristics. The Equality Act, for instance, have got the characteristics below that are covered. So you can see here that includes gender reassignment, sex and sexuality as well. And this is to protect these characteristics from discrimination. Whereas the Gender Recognition Act, released in 2004, apologies, is to allow individuals that are over 18, so people that are recognised as adults, to have their acquired gender legally recognised. And therefore, that also makes it illegal to disclose any of that information on someone's gender without their consent to somebody else. So that's very useful to know when relaying someone's identity within their healthcare workforce.
So in terms of allied health professionals, there's lots of guidance out there, and, you know, the GMC is always a good first place to look. So if we have a wee look at good medical practice, it's really clear in terms of how we must treat our patients with kindness, courtesy, and respect in a non-discriminatory way, ensuring that we don't bully or harass or abuse anyone based on their personal characteristics. So it's all out there, and gender reassignment is obviously listed as one of those characteristics there. The NMC also has bits around this, and this is the kind of stuff that we kind of highlight to students throughout the course, is that they have to be abiding by these principles in order to practice as clinicians. So the information is very much there, and the expectation is very much there also.
So when we then start talking a little bit about LGBT people and the health inequalities that they experience as a population, we start getting some of these types of statistics that you'll see here. So for instance, we know that there's now a higher risk of cancer in lesbian and bisexual women. And you can see in the study below that one study showed a 10% higher risk of breast cancer among bisexual women and a 6% higher risk among lesbian women when compared to the average heterosexual cisgendered woman. Then other parts of healthcare inequalities, trans and non-binary people between the ages of 16 and 44 are much more likely to report long-term illnesses, conditions, and disabilities. And there at the bottom, 52% of LGBTQ plus people have reported experiencing depression in the last year. There's a wide array of health inequalities that we see. There's also things such as the transgender people, we've recently found in studies over the last 15 years, have a higher incidence of autism and ADHD. We find that there's higher risks of eating disorders in transgender teenagers. And with all of these things, we have those statistics, but we don't often have like biomedical or pathophysiological reasons to back them up. And a lot of it comes down to different things such as risk-taking behaviors. It comes to discrimination, bias within the kind of the healthcare workforce. So there's lots of variety as why someone might go through these different things.
So thinking about the NBCHB and our careers, we'll just talk you through some of the things that we've been finding. Will, I think you may have frozen. I'm hoping you're able to change slide. Have I frozen? Oh no.
You've not frozen.
I've not frozen. Will has.
I think it's just Will.
Apologies, okay. Am I back?
He's back. He's back.
You're back.
Apologies, I can't see you. I am so sorry. When did I cut out?
So I just started talking about NBCHB curriculum updates.
Okay, not a problem. You can carry on.
Cracking. Would you be able to move on to the next slide for me, my love?
I absolutely can. Sorry about
Thank you
that.
so much. Yay, there we go. So one of the things we've been working on recently is mapping the current curriculum, having a look at what we're already doing. The majority of LGBT plus education comes within the current comes within year 3 in the current curriculum. So there's a small group session in GP around LGBT plus and gender incongruence, which features some cases of trans and non-binary patients. Also within the reproductive health block, a lot of this falls. So I do the LGBT, trans and non-binary people's experiences of healthcare lecture at the end of March. They also have a lecture around sexual health for LGBTQ plus individuals. And there are some comm skills scenarios, thinking about sexual history and that sort of thing, and also clinical skills scenarios as well. And this year, come May, we will be launching the first EDI SSC for year 3, which is going to have a whole range of different marginalized characteristics and conversations going on within it, but obviously LGBTQ will be playing a sizable part within that. So we're hoping to use that to broaden things out a little bit. If you could go to the next slide for me, Will. Fantastic. So in terms of where we go with this, we're trying to work out what's happening elsewhere in Scotland. So we've started to form relationships with staff and lecturers and academics working in other medical schools in Scotland. So, for example, Edinburgh has effectively a trans health block, a mini trans health module, which lasts a couple of weeks, I believe, within their curriculum towards the end of it. But it's very, very patchy as to who's doing what where and trying to get a good handle on that. One of the other projects that Will is leading on with a couple of our third year students is around creating a student survey. Recently, the University of Dundee as a whole was sadly voted the least LGBT friendly university in the UK. And we can't disaggregate any data down by schools, but it's still, a very concerning statistic to see. So that survey is going to be looking at not only the experiences of LGBTQ plus students and the kind of culture, the experiences they have, but also asking them about the kind of teaching they've received as well. The thing I really want to think about is how we can almost microdose LGBTQ plus content through the curriculum. One of the big challenges we have is we're very specialty based. We work in these specialty blocks. And as a community, we don't fit neatly into one block because we all have a whole wide variety of health experiences from a whole wide variety of specialties. So it's more about thinking about each individual specialty and particular health inequalities that the LGBTQ community might experience within that specialty. So, for example, if you're giving a lecture on oncology, for example, you could put in an extra slide talking about the fact that lesbian and gay women have higher rates of cancer. Why could that be? What's the mortality rates in comparison? So rather than trying to just put in block lectures every so often and relying on that, we think it'd be really powerful to put in individual slides throughout and kind of give students this kind of constant normalizing of the LGBTQ plus community to get them thinking about it. Another practical way we can do this is looking at scenarios and OSCE stations. So I was having a conversation with a colleague at a different medical school recently, and we were talking about how if you had a scenario, a comm skills or clinical skills scenario with a patient coming in with a neurological condition, say Parkinson's, and he comes in with another man in the room, getting the student to get comfortable saying, okay, can I just check what your relationship is? Making sure, they know how to respond. They don't, if that person comes in with a husband as opposed to a wife as they may be expecting, just normalizing these relationships, but not in a way where it's there are two gay men, so it's going to be a station on sexual health type conversation. We just want to keep reminding students that they will come across trans and non-binary LGBTQ plus people throughout their medical careers in all ranges of different specialties, and it's really important they understand that and they understand how to interact and how to acknowledge the health inequalities these communities face in order to try and challenge them. So as a part of doing all this, we're going to need to do some significant staff development, because I know from speaking to staff, it's an area that many of us didn't get taught anything about in medical school. Many of us who've taken an interest in this have very much kind of garnered that on our own accounts. So people have said to me they'd really love to have some more staff development around this, and that is what we're working to do. So I will pass over to Will to tell you about his fantastic project.
Yeah, so we've called this the postgraduate learning opportunity. As part of my role as a clinical teaching fellow this year within the University of Dundee and in NHS Tayside, we get our weeks are split up differently in that we have so many days that we work on university undergraduate based things, and then we get kind of 2 sessions to work on a postgraduate project, and that can be a variety of different things. As part of this year, I self-proposed a project about increasing awareness of LGBTQ plus healthcare within postgraduate populations. And one of the best ways we found to do that was looking at if you are someone that is within the workforce that is a supervisor, we might target yourselves in a workshop as part of your recognition of trainer training to increase your knowledge about these things, and actually therefore how to then supervise a diverse population and workforce within that. So that's where this project is created, this supervising a diverse workforce and LGBTQ plus edition. So my first session for this is actually on Thursday, the 5th of March. So that is next week, and is running for an hour and a half. Unfortunately, it is already fully booked. However, if you would like to join the waiting list for this, and if it's something that you might be interested in, you can scan this QR code that's currently on the screen for you now, and that will take you to put your name in. And once we've set up another session, hopefully in the next 2 to 3 weeks, we can hopefully get you on that. The session itself, I've put the learning objectives up there for you to have a look through, but the session is split into 2 sections. It's a first maybe 45 minutes of teaching you the information, letting you kind of learn the information about different identities within the LGBTQ plus community, as well as starting to consider the health inequalities that that population faces. And then the second 45 minutes is a reflective exercise using tabletop simulation, where you are given cases that are all based on real life stories that you'll go through, and you'll act as different kind of characters within that situation and scenario. And then you'll all at the end have questions that you reflect on, and you talk to one another and formulate a plan of how you would do things differently. The reason that it's supervisors is that it's based around, if a student had witnessed something, what would you do as a supervisor? What would you do if you'd also witnessed it? And it's about creating a plan for both scenarios in that case. And that's available for anyone that would like to come. It was originally that it was going to be for kind of consultant supervisors, but actually it would be relevant for anybody that supervises from all different types of allied healthcares as well. So if you were interested in it at all in learning about this type of thing, please do put your name on that waiting list, as I'd love to see you. But yeah, is that okay for us to move on?
That's fantastic. Thank you, Will.
Fabulous.
So yes, once Will has run some of those sessions, we're hoping to kind of look at how we can expand them out and think about wider staff development. So, for example, supporting comms tutors, small GP, small group tutors, people who don't necessarily get massive exposure to this topic. I think there's a huge amount of anxiety around teaching it. People get very worried about saying the wrong thing, getting things wrong. But as I am forever saying to the students, I don't mind if you get things wrong, as long as you go into it with an awareness that you may get things wrong. You're open to apologize and you're opening to learning, so we can continue to improve. And I think that's a basis for a very strong medical career. So please don't be put off if this is an area you've always been a bit worried about. That is the entire point of running this staff development.
Absolutely.
So I just wanted to kind of round up today by talking about my work around gender services in NHS Tayside. So at present, the vast majority of patients from NHS Tayside who are referred into gender services are being seen in Sandyford in Glasgow. Sandyford covers 7 or 8 health boards, I think, across Scotland for gender services. We have 4 gender services in total in Scotland. So we've got Sandyford, which is the big one, then Highlands, Grampian and Lothian as well. So yeah, we all feed into Sandyford at present. There's a bit of a convoluted route for referral. So GPs are asked to refer to the clinical psychology team in NHS Tayside, who will assess the patients. And then if they feel that the referral to gender identity services is appropriate, they will then apply for the funding for that and put the patient on the waiting list for the GIC in Sandyford. The data I managed to get out of Sandyford last year around June time, at that point had 422 NHS Tayside patients on their waiting list, alongside all of the other health boards that were feeding in. However, we know that the numbers are increasing exponentially as more and more people try and get on the waiting list, knowing that it is a very long list indeed. Currently, they are offering first assessments. So in Scotland, you only need one assessment to start hormone treatment, and they are currently offering that first assessment to patients who were referred in 2017. However, last year they managed to provide, I think it was 42 first assessments in the entire year, and there are almost 4,000 patients on the waiting list that we've seen from the latest data. So if you work out how many appointments that is per year versus how many people there are on the waiting list, the most hopeful estimates show that there is likely an 80-year wait to be seen at a gender identity clinic in Sandyford, which is frankly terrifying. This is a population who experience massive health inequalities and huge challenges, many of which can be addressed if they're given appropriate and timely care and support. And by failing to provide that, we know that the increased rates of poor mental health, suicidality, risky behaviours, things like dyslipidemia, all sorts of things massively increased if you don't provide timely care to this population. So it's a tricky one in that a lot of my GP colleagues, very understandably, don't get much training in this, don't feel particularly confident in starting hormones, doing bridging, that sort of thing. But these patients are often left with absolutely nothing if they can't get into a GIC. So whilst we're not seeing these patients in a GIC, these patients will be back at their GP over and over again because they have so many other challenges which could potentially be managed if they actually saw the GIC they needed. So clearly the current situation is not tenable and not a long-term option. I spent the first 6 months of my role developing gender services, basically interviewing people working in gender services across the UK, looking at different models of care. And many of the newer models that are working very well down in England and indeed Wales, where it's entirely GP-led, are these GP-led services. So it's GPs who've taken a special interest, done additional training within a service to learn to be gender consultants. And they will manage much of the care of these patients, the assessment of these patients, prescribing and monitoring with, endocrinology and psychology backup as and when it's required. So what we've proposed at present in Scotland, all the services are endocrinology and psychology led. What we've proposed is a GP-led gender clinic in Tayside, which would be the first of its kind in Scotland. And we're hoping for that to be an integrated medical and surgical service, potentially based out Stracathro. So many of you will know the wonderful Mr. Mike Ung, who is based at Ninewells. Mike's a phenomenal plastic surgeon who has been trained in all the different gender surgeries, but at the moment doesn't really get to do very many because currently all of our patients are sent down to England under a Four Nations contract. The only exceptions for that are occasional chest feminizing surgeries and occasional facial feminizing surgeries, but these are very hard to get referred in for. So Mike will do those and we'll do revisions. But if you need a chest masculinizing surgery or bottom surgery, you're going to go down to England. We will cover patients' transport fees and hotel fees to do that if needed. But that doesn't necessarily cover people going down to support them. If you're going all the way down from the Highlands down to Plymouth, for example, for a surgery, you're not going to be able to jump back on a train and start hoiking bags on and off immediately after surgery. So you may need to stay in the area for a bit longer, but you won't be able to stay in hospital. So that all these potential accrued additional costs which aren't being covered for patients. So it's a big outlay for the patients engaging in this. We would really love to see a surgical service based in Scotland. There are huge numbers of people waiting. And I've even had people from the northeast of England in their services going, do you think maybe we could make the most of this if that were to open? So there's definitely appetite. So what we'd love to see is an integrated medical and surgical service. There is no such service in the whole of the UK at the moment. The two tend to work very separately. So you'll have your GIC who will do the assessments. They will then refer you into a surgical team elsewhere, often London. And you sit on that waiting list and then you hopefully see them. Whereas we think there's real power in offering a holistic service. Some trans non-binary patients will want the full gamut of treatments. So they might want hormones, surgery, voice therapy, hair removal, all of these different things. Some will just say, actually, I want support, I want psychological support, I don't feel I want hormones, I don't feel I want surgery. And many will be in the middle of that, will have their own requirements. So whilst not everybody is going to want everything, it's really important that that is an option. And we think that creating a really holistic medical surgical integrated service is a great way of providing that and could be really unique. So that's the proposal that's currently gone out, and we're waiting to hear what's happening about that. But we do have some backup plans, because obviously that's not a small outlay. One of the challenges financially for this cohort is that whilst they're sitting on a waiting list, they're not costing anyone any money. So NHS Tayside only pays Sandyford when these patients are seen, and so as such there's not a big pot of money sitting there being unused at the moment. So a backup plan would be to try and get the surgical service off the ground, at least in Stracathro. And we're in conversations with NSS and, as it still is just about, before I think it becomes PSD, PDS, one of the two. And we've also had discussions with Scottish Government as well to look at whether we could create a Scottish-led service, which would be phenomenal. We're also looking at the potential for a GP-led bridging service. So for patients who come into their GP and say, you know, I'm really struggling, I really need to be on hormones, but doing it privately is financially very expensive or very high risk. I've spoken to patients who are using estrogen that a friend of theirs has brewed in their kitchen. So the way that people are accessing these medications can be very, very high risk, particularly if there's no monitoring. If we can get GPs locally trained up who are willing to provide some bridging, so prescribing for these patients whilst they're waiting to be seen, I think that would be a really, really helpful and harm-reducing service. We could also look at a reviewing and monitoring service. So as soon as patients have been seen by the GIC and started on medications, we could then take over doing the regular monitoring the bloods every year or more regularly if needed, and prescribing long-term, because that would help tackle some of the challenges between the primary secondary care interface that this patient group seem to experience. And alongside that, we'll need to think really carefully about staff development. So how we make it a service that can carry on going for however long it's needed. So yeah, thinking a lot about training. And some of you will know I'm currently working on the creation of a master's PG-DIP PG cert in gender healthcare, which would be the first of its kind in the UK, if not the world, in the hope that we can continue to train staff of all different types to work in services like this. So yeah, I think that's my very, very potted rant about gender services, and that kind of brings us to the end. I don't know if Tom has managed to make it back in yet. He's popped in the chat that, thank you, Susie. He's popped in the chat that he's been called away. If anyone has any questions, please do pop up your hands, comment in the chat, whichever suits. Stunned silence, delighted silence, hopefully. I'm just looking across. I'm seeing no questions, which is wonderful.
I'm trying to stick my hand up and can't work out where it is.
We can see you, Susie. Hi.
I'm too used to Teams. No, really, really interesting. So, okay, so thinking about your strategic plan on all this, what are your measures of success at the end of 12 months? And how can we help you achieve those?
So are you asking about any particular aspect of it, or the curriculum, the gender
what
service?
You think are your absolute priorities? So
absolute priorities. For me, I would like to get some regular staff development sessions running in the next 12 months, particularly around those who need small group teaching across the university, because that's an area that I've had people kind of come up to me time and again and said, we need this, we feel a bit anxious and uncomfortable teaching this. So the absolute priority for me is to get those sessions running within the next year and hopefully relatively well attended. So then we can kind of look with my EDI hat on at making sure we're doing training around other marginalised characteristics as well. So my aim for that one is to get that running and to start seeing other specialty lecturers saying, right, Hannah, how can I get some health inequalities, LGBTQ plus education within the lectures I'm already giving? So I would like to see that kind of micro dosing starting to be seen throughout the curriculum. I think that's going to be absolutely key from a curriculum point. So if I can do that in the next year, I will be delighted. I think in terms of the gender services element, I'm sitting twiddling my thumbs a little bit, waiting to hear as to what funding is going to be available when and what's happening. But my next step is that I've got 2 different services, potentially Wales and or Edinburgh, offering to train me up as a consultant now. So hopefully I can at least get trained up so I can be qualified as soon as we're ready to get going to either do the bridging, the reviewing, or the monitoring. So whilst I'm not sure we're going to have a fully functional all singing, dancing service in the next year, that's probably woefully optimistic on my part. It would be great to have some kind of clinical support in NHS Tayside for this work.
And do you see that extending across the faculty? Now we're going to be a faculty, or are you very much focused on MBCHB?
Yeah, so interestingly, the master's program that I'm putting together that we've discussed, Susie, I'm doing in collaboration with the School of Health Sciences. So my co-lead is Alice Einian, who's very senior in that school. So I'm very much hoping that once we've started doing this stuff, we can then have those conversations and say, this is how we're doing it. What do you think? But I think it is really important that we don't work in silos, both in terms of faculty and in terms of other universities. So that's why I'm trying to do that background work and working out who's doing what and getting good practice from elsewhere, because it's an area that's being taught in hugely varying degrees across the UK. So there needs to be something going on.
And I see Tom is back, and you have a question in the chat from Alex, so I will switch my audio. Thank you.
Thanks, Susie. Apologies, I got called away, so I did miss some of your talk. Apologies for that, but I'll be able to watch it back on YouTube once I've got around to editing it. So thank you, Susie, for standing in. The Alex here is asking the same question that I was going to ask. Are you in contact already with the lecturers to add LGBTQ plus information to lectures? Are you seeing interest from them? My comment, I suppose, is that it's the respiratory block at the moment. So I've spent a lot of time studying the Wolfson Lecture Theatre this week, speaking to first-year medical students. And as you were saying, can we microdose or drip feed in throughout the whole? So, well, I've given maybe 8-10 lectures in the last 2 weeks. What would I have put in? And I'm not sure I know. I don't know the data. I can't tell you the same data that William was talking about in terms of breast cancer, etc. I don't know that for respiratory illnesses. I know it for deprivation and poverty, and I know it for race, and I know it for color of skin, and I know lots of things, but I don't necessarily know it for these issues. So can you help me, and can you answer Alex's question as well?
So yes, I would be delighted to sit down and have a chat. I think there is data out there. There is more and more research being done. So, for example, we know that traditional smoking cessation methods are less effective for gay men. I can't necessarily tell you why, but we know that they are less likely to engage with and succeed when it comes to traditional smoking cessation. And then thinking about increased risky behaviours, that does see an increased risk in COPD, in lung cancer and that sort of thing. So I think it's one of those things where as and when I get to different specialties, as and when different specialties get to me, I'm very happy to sit down, do a bit of data crunching and see what we can add in, because I think there's a whole lot of Johari's window unknowns going on here. But yeah, so at the moment, in terms of Alex's question, I am starting to make contact now in the next couple of weeks. So this talk is very much intended to be a bit of a launching platform for it. So if this is something that anyone's sitting out there going, oh my goodness, how do I get this into, I mean, there's quite a lot of it in the repro block, but into different blocks around psychiatry, whatever it might be, please do get in contact, and I will gladly try and sit down with you and we can find out where we can squeeze some of this stuff in. It shouldn't be a massively onerous task, and I'm happy to help in any way I can.
So, any other questions from the virtual floor? I've just do what we always do in these situations, is Google the answer to our own question, and there is research, as I'm sure you know. So even in October 25, there was a paper which was in the Royal Society of Public Health journal, Sexuality and Respiratory Outcomes in UK, Disparities, Development and Mediators in Multiple Longitudinal Studies. Take a breath. So there is data. I'm going to go look at that after this talk and try and see if I can insert it into my slide. So that's great. And I think this is what's so great about this series of talks, our Black History Month talks, a range of the different talks we hear. It's just bringing back into our minds these things which we don't. It's not that we're ignoring them. I don't think any of us is ignoring these issues. It's just I reflect on the medical school curriculum that I was taught 30 years ago, the medical school curriculum when I was involved in the medical school 10, 15 years ago, and what it is now, and just the sheer volume of it,
Mhm.
the breadth, the depth, it's huge. And we're trying to fit in so much, but this is such an important thing, and I think it's great that you've been able to highlight this to us all. Any other questions from the floor? Doesn't look like it. So that's great. Well, thank you very much to both of you for your presentation. Apologies for having to leave. Clinical medicine sometimes gets in the way of these grand rounds, but I'm grateful for everyone coming. I will edit this over the next week and put it onto our YouTube channel to add to the previous 10 LGBT month talks that we have on that channel. Next week, I'm not here. I'm on holiday. But Professor Hothersall Davis will be speaking, and I'm sure we'll drum up a chair somewhere to introduce her. And she's going to be talking about scholarship in its under the title of scholarship. But I think her exact title of talk is "The Future of the Medical Curriculum." So that will be interesting. The week after that, we have Sean Laverick talking about some of his charitable work that he is doing in the facial surgery sphere. And then I have 2 blank weeks. So if you're sat there on a talk, please do get in touch and we'll offer you a slot. Thanks again to both of you and to Susie for stepping in. And I will see you all when I get back from holiday. And next week, you can look forward to Ellie's talk. Thanks very much, everyone. Take care. Have a good weekend.
Thanks,
Thank
Tom.
you. Bye.